um, and be with y'all today. Um, you're going to be kind of the guinea pigs on my end of it, from the standpoint of what I'm going to do is I've created a new neuroscience series that's going to be released beginning in January that covers most of the mood states of substance use and psychiatric disorders from a neuroscientific standpoint. Today, we're going to talk about the neuroscience of trauma on psychiatric and substance use disorders. And so with that, we will begin because it's a fairly long discussion. I'm hoping we'll be done by 12, but I declare no conflicts of interest, no funds in any product, company, or whatever that's going to be given during this presentation. The first thing I want to do is give resources. Some of you may be familiar with these, but I'll share these with you. Some recent resources that I've discovered that have been very helpful with substance use disorder and trauma issues. The first one is from SAMHSA. It's a concept of trauma and guidance for trauma-informed approaches. It's a handbook for multiple levels, professionals and practitioners, very helpful in giving information on what education needs to be given to information about trauma, the types of trauma, and interventions of that trauma. So I use that substance concept of trauma and guidance for trauma-informed approach. Of course, the one that has been out for the longest, and most of you have probably been trained in by now, of course, is Tip 57. This is my textbook when it comes to teaching trauma. I use this as the background of my approach to sharing information, plus the new research that may be coming out. And then I have a friend that has come out with one of the finest group therapists that I've ever known, worked in the field for 40 years, has recently released a book called the Retired Dragon Fighter series, Dancing in the Light, which is probably, after my review, one of the best books on approaching trauma and discussing trauma with individuals and calling the effects of trauma the dragon. And so I won't go into that. I'm not here to promote it. I don't have any investment in the book. I'm just sharing this is a great resource, very readable and very helpful from the standpoint. And I think he said you could get these from Amazon.com. So I'll share those three resources with you. So let's talk about the neurobiology of trauma and what I deal with a lot. 15, 20 years ago, when we looked at substance use and trauma, we separated them. There was substance abuse components in treatment, and then there was mental illness components in treatment, and then there was trauma. If you address trauma, if people had been trained to understand what trauma was, usually it got avoided. But in 20 years ago, things have changed. And so when we look at it today, we see it as this. We see trauma overriding both mental illness and substance abuse. And the thing about it is we're going to talk about how that impacts individuals from the standpoint. The question always comes up, does trauma cause substance use disorders, or does substance use disorders cause trauma? Well, my information that I get is that both trauma and substance use disorders cause changes to the brain's functionality and neurochemistry. Both trauma and substance use disorders activate what we call the anti-reward brain, or what most people will call the pain brain. And it's regulated by neurotransmitters of glutamate and GABA. Both trauma and substance use disorders deplete and shut down what we call the reward brain, or what you may call the pleasure brain, which include dopamine, endorphins, and serotonin. Both trauma and substance use disorders both activate the stress response system in the brain. The primary difference is that trauma can change brain pathology and chemistry within seconds, whereas substance use disorders, depending on age of first use and other things, may change it over a period of months or years. And the thing that I underline with all of this, that recovery from both trauma and a substance use disorder will take lifetimes of effort. If we look at how does trauma change mental health, of course, most of you know the brain is incredibly complex. It only makes up about 2% of our body weight, but it consumes 20% of our oxygen. and we breathe, and it takes up 20% of our energy. So people want to know, if I'm not walking or talking, but I'm thinking, you're still losing weight. Just keep that in mind, y'all. Just keep that in mind. It controls virtually everything as humans experience, including movement, senses of the environment, regulating involuntary body processes, breathing, controlling our emotions. There are hundreds of thousands of chemical reactions that happen every second in the brain. And these reactions underlie the thoughts, actions, and behaviors. As I tell everyone, in short, the brain dictates the internal processes and behaviors we survive. We are in the brain regulated by the central nervous system, which is converting chemical energy into electrical energy back into chemical energy. And that is the purpose of that central nervous system. And so anything that impacts that central nervous system will impact us as humans. We also have what we call the true brain. It's made up of basically three levels. We have the reptilian brain. Most of y'all remember this from your biology. It is our survival brain. It is what has evolved over hundreds of thousands of years. And we created what we call the mammalian brain, because humans are mammals. Helps us process emotions of joy and fear, and it helps us regulate our attachment. And then we have what we call the neo-mammalian brain, which is responsible for the more complex sensory processing, learning. It's the new brain area. It's the evolving brain, that brain that still continues to expand and grow as we move as a species. When we experience trauma, the brain shuts down all the non-essential systems and activates the sympathetic or the stimulant nervous system in the mammalian brain. To help us survive trauma, the brain also releases stress hormones that activates our instinctual survival response of fight or flight. So we shut down everything that's essential or non-essential and go into survival. And then also we move into fight or flight. So that's what trauma will do to our brain. Now, Dusty Miller said, for those who suffer addiction and trauma, the greater difficulty sustaining abstinence because of the trauma-based physiological responses, emotions, thoughts, and relationship patterns. Trauma-related distress continuously stimulates the addiction compulsive component, because trauma diminishes dopamine, and what you will find out in probably not this lecture, but dopamine is responsible for the reduction of compulsivity in the prefrontal cortex. And so when we have that compulsivity and we have not enough dopamine to stop, we become compulsive in our patterns of use. And so that's one of the things that I will tell you. It's a cycle. Most of us have identified in the substance use treatment field that trauma occurs earlier than substance use as a rule. It creates tremendous emotional upheaval and diminishes certain chemistries that lead into psychiatric, depression, anxiety, all kinds of thought disorders. And people will use psychoactive chemicals, which actually help them feel better from the emotional upheaval. But what happens is, as they increase their use, it creates also the decreased ability to learn new skills of how to manage the trauma behaviorally, and process actually what the traumatic material will be. And what this can do is that continued use over time can lead to a substance use disorder. And then as a result of a substance use disorder creating further diminishment in the chemistry of the brain, it creates re-traumatization, and this cycle spins around and around as a tire stuck in the mud, so to speak. And substance use disorders are extremely complex. They're biological in nature, they're sociological, and they're psychological. The biological component is the chemistry, the neuroscience that I talk about. And if I could just detox people and stabilize the brain chemistry and send them home, that would be a wonderful thing. But what we find with people with substance use disorders, that is not what happens. We can detox them 100 times and they still have the psychological thinking, craving, and others. And then, of course, the sociological issues in our country has to do with stigma and shame and components such as that people, it is an embarrassing circumstance, invariably, for families to have an addict or an alcoholic in the family. Depending on gender, it has the level of severity. If your mother's alcoholic, much more shameful, at least in most families, than it would be if the father was an alcoholic. So It's not as accepted for women as it is for men, but both are extremely creating stigma. So when we look at this brain and the levels, we have the tremendous 12 neurochemical families. And I don't have enough time to explain these. You can read these, but as you will see this list, we have norepinephrine and serotonin and GABA, the endorphins, acetylcholine, anandamide, histamine, glutamate, dopamine, oxytocin, PIP, and dynorphin systems. All are responsible for normal human behaviors. And as we see, we have this rewards brain, which is responsible for pleasure, especially when we do things that helps us survive, or we satisfy our hunger, or we motivate the species through sex, or we quench our thirst. It helps us survive, or we create relationships, and we call them connections that create reward feelings, especially if our great friends or our families or whatever. And what we see is that alcohol and drugs can replace those instinctual needs because they have a greater release of the chemicals responsible for that, primarily dopamine, the endorphins, dynorphins, and oxytocin. Those are the four players that we will talk about and we've discovered recently in this reward system. Now, simply put, I have two different components to this, and I'll move this. You have a human doing, which I considered a person with a substance use disorder, and a human being. And so if we want to look at the differences, we will see we add the tremendous 12, which are the normal chemistry that's available. And we will see that substance use disorders / trauma, depending on which may occur first or second, will come in and will create a decrease. The first thing that we lose, that most people don't know, two things that we lose: attachment to those that we care the most about, and our natural loving. And then we lose our fun, and then we lose our anxiety management, and then we lose our memory, and then we lose our bliss, and then we lose our organizational skills, then we lose our pain management skills, and then we lose that the genuine pleasure component, and then we lose our sleep component, and we end up with what we call epinephrine, norepinephrine, fight or flight, stress-driven brain that creates compulsivity and repeated behaviors and self-destruction, et cetera, et cetera, et cetera. And then we have the recovery, as if I can move this, the recovery piece. And so as we see this recovery piece move in here, then guess what? We try to put people in treatment, and we will increase those chemistries, and people heal from an addiction. And most of y'all have seen that. So what happens, Merrill? We can deplete it depending on if it's trauma or substance use disorders. Trauma, as I said earlier, takes seconds. And if they're 14, 15, 16 years old, they can deplete this chemistry within 12 months, depending on drugs of choice. Well, how long does it take to recover, Merrill? How long? We look at multiple studies. It takes a minimum of 5 to 7 years of abstinence-based treatment to recover most of these chemicals. The sooner that you intervene on a younger brain, the better chance they have for that brain to fully mature. If this brain is past age of 25, 26, and it happens, it really does not ever get back to the level it was before in what the science has shown us. And we create what we call an anti-reward brain. And what I want y'all to know about this anti-reward brain, the key element is a negative emotional state during drug abstinence. Why aren't people happy to go to treatment? Why aren't people happy to go to meetings and follow directions of treatment professionals and do the things they need to do? Is because the brain will not allow them to experience pleasure of those activities because it's in the anti-reward brain. That's the job of the anti-reward brain, is to eliminate all pleasure. So it takes time of abstinence for the brain to reactivate the reward system. And so what we see is that's what a lot of the treatment programs will tell you, but we have short-term treatment in this country. Very rare do we have treatment. How long does it take? 12 to 24 months, 12 to 24 months. And people will go to 6-week programs or 10-week programs or 12-week programs, and then they relapse after 2 or 3 months. And people say, well, why didn't they get it? Well, it's because the brain didn't heal quick enough, soon enough to deal with the ongoing issue of stress. And as George Koob, who's the NIAAA director now, says, we have multiple reasons for that to happen. So if we look at this brain and we see all these activities of these areas, we have to manage all of these chemical areas in order to avoid relapse. And so he says, how does it start? It starts out with the reward brain. People get intoxicated, whoopee, whoopee, and we have that stimulation of euphoria and feel good. Now, as a result, and this is not a substance use disorder, if we stop drinking or using, we will go through a withdrawal, and that will be ouch. So we have these issues, whoopee, ouch, whoopee, ouch, whoopee, ouch, through periods of use. But what most people don't know is that 89% of the population who drink on a regular basis continue to have this balance. 11% of this population simply does this. They will go whoopee, ouch, and that brain continues to deplete the blue area, and they just end up with ouch, 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 or the anti-reward brain. And as the anti-reward brain drives the behavior, they will simply believe that all I need to do is take more drug in order to get back to some sense of balance. Do you understand? They're thinking they can get back to sense of balance, but because as they continue to use and deplete the tremendous 12, what it does, y'all, and most people don't know this, it creates further withdrawal or a greater ouch. And as that ouch gets extended, the brain tries to manage it and said, I've got to have something to manage this craving and this stress. So what it does, according to the researchers, Koob and Vogtnow, which are the experts, it creates the craving brain. Now, I want you to look in the green area of this craving brain, the area what they call preoccupation and anticipation, where they continue to think about the drug even though they may not be using the drug. There's an area called the insula. The insula is that little green area on the bottom. Now, we won't talk a lot about that, but what I've discovered as it relates to trauma and shame, it is the fifth cortex, and it is involved heavily in this compulsive craving component. And so the thing that most of the new researchers are talking about, how do we manage the insula? We think if we can manage the insula, we can manage and diminish craving and preoccupation, and that way it gives a person a time to behaviorally change enough in order to grant themselves abstinence for a prolonged period of time. Stress is a big deal, y'all. It's huge. So if we don't have a balance between the reward neurocircuit and the OCD neurocircuit, and we deplete that reward neurocircuit by depleting dopamine and the endorphins and dynorphin, oxytocin, what we end up, y'all, with there's no reward neurocircuit available, we end up with an OCD neurocircuit here, and it's full of that negativity, as I said, that negative attitude towards addiction. And allostasis is a part of the brains, and allostasis means the brain has the ability to achieve stability through change. And to obtain stability, an organism must vary all the parameters of its internal milieu and match them appropriately to the environmental demands. This has to do with the management of stress. So what people have to learn to do is not only do they have to learn to stop using their psychoactive chemicals, but they've got to learn also behaviorally how to manage their day-to-day stress. So the question is, does trauma cause substance use disorders, or does substance use disorders cause trauma? Again, the same question I asked earlier. Both trauma and addiction activate the anti-reward brain system. They also activate the stress response system. So you've got to deal with the pain brain and the stress brain simultaneously. Trauma creates that same event within a matter of a few seconds or minutes depending on how long the trauma is, they're exposed to the trauma and how long the trauma lasts. Some people have trauma for a few seconds or hours as a result of some sort of physical trauma or combat trauma or others. Some have this type of stress for years as a result of sexual abuse and other types of trauma along that way. And again, recovery from these not only takes effective intervention, but also a lifetime of effort to keep yourself out of what we call the relapse to manage. So then we have Koob. It's also come out, said that recent studies indicate there's changes in the kappa, the dynorphin system. Now, the dynorphin system has been studied recently over the last decade. And chronic stress, such as post-traumatic stress disorder, taxes the kappa opioid receptors, however, causing those receptors that respond to dopamine and endorphins to retract inside of the cell, thus leaving no place for the dynorphins to really land. As a result, the patients experience dysphoria, hopelessness, detachment, and emotional unease. And as you can tell, when there's a change in the pathophysiology as a result of these underlying receptor systems, there really becomes a very desperate situation for the individual. So when we look at traumas, and these are the basic types of trauma, we have an acute trauma, single event. If you were in an automobile accident and you either had a loss of life or someone in the car or someone in the accident itself, but it was only one time, then you can have that acute trauma, which can create the symptoms of post-traumatic stress. We have chronic trauma, as we talked about, is the experience of multiple traumatic events, such as combat, sexual abuse, and other types of things. We have system-induced trauma, which is a traumatic removal from the home. Adoption is a huge trauma. Most people don't realize that. It's a huge trauma to the individual. Admission to a detention residential facility. People admitted to treatment is traumatic. Multiple placements within a short period of time within juvenile justice. Those types are examples of system-induced trauma. And then complex trauma are both exposure to the chronic trauma and also the impact of the exposure has on the individual, such as system-induced trauma. So you can have a traumatic event in the individual and they have to go to treatment, or they go to juvenile justice, or they go to someone, and they have multiple complex traumas, which require specific interventions to effectively treat. So what does it do to us, Sean? What does trauma do with all this neurobiology? It really sets up a set of unfocused responses to how we manage our stress. And it can create impairments of attachment. It can create impairments of sensation and movement, create hypersensitivity to contact, insensitivity to pain, physical symptoms, increased medical problems. It can have all types of impact on psychiatric disorders, mood regulation, behavioral control, disassociation. It can have problems, people in cognition and functioning, self-concept, loss and betrayal, powerlessness. The problem is, the consequence is the impact on the normal development of children's brains and their chemistry. Trauma-induced alteration to biological stress symptoms can affect brain development, as I'm fixing to show you in a minute. It also results in ongoing increases of stress hormones that the brain cannot appropriately manage or break. It creates a highly stressed brain. And when you have these highly stressed brains, it affects what we call the crosstalk between the left and right hemispheres. And it creates mixed messages in the regulation of emotions. So a person can be fine one second and angry the next. It can alter fears and anxiety and create overly aggressive or underly aggressive folks. It can create sustained attention and learning problems, controlled impulses, and manage physical responses to danger. You have high-risk individuals who will put themselves at the highest risk whatsoever with no sense of danger. And then you have people who develop agoraphobia because they're afraid that anything could happen once they walk out the door.
promotion and consideration of consequences, and ability to govern behaviors. All these types of things are a result of significant trauma. So you have the 3 E's of trauma: the event, actually circumstances of what happened; the experience, what the perception of the event was by the individual; and the effects, or the adverse effects of the degree that impacted the individual the first week, the first month, the first year after the event, if it be the ability to cope, the ongoing well-being, those types of things. So traumatic event is one in which a person experiences something that is frightening and overwhelming, and that it entails a sense of a loss of control. Now put that together. It's frightening, it's overwhelming, and it entails a sense of a loss of control. In experiences of extreme threats, such as a rape or torture, it can feel like the threat to one's ability to survive. But the events are viewed subjectively. This expansive trauma definition is more of a guideline, and that's why I give it to you. So when people start talking to you about an experience they may have had at home or at school or on a date or whatever, one, is it frightening to them? Was it overwhelming to them? And did it entail a sense of loss? That will give you some idea of the level of what this may be. Everyone processes traumatic events differently because we all endure them through the lens of early experiences of our lives. So depending on also previous traumas and the recovery of traumas, this is how we manage it. So that is trauma. So what do we do? And how do we defend it? Well, I won't go into all of this. I'll let you read this, but there are multiple levels of experiences that I'm going to go into. The overall reactions to threat of trauma are fight, flight, and freeze. Most people are familiar with these. They register at 2 levels: cognitive or conscious and unconscious. The field of neuroscience is moving to understand both of the systems. One system generates conscious feelings of fear and anxiety. The second sets up the behavioral responses to that threat. And that's the thing that I will tell you is, what do we do and how do we study this? We have the 5 senses that interpret what this is, and they activate the cascade of stress chemicals. It goes to the brain, and the brain will then switch into a fight mode, a flight mode, or a freeze mode. And there's actually a couple more that we will discuss in a minute. And then what we do is it creates a release of hormones. And this hormone system activates the HPA axis. And the primary player in this is an area in the brain called the amygdala. And this amygdala can be informed about something as fearful or threatening before the cortex even knows what's going on. So your instinctual brain, remember, the reptilian brain triggers that gut that you have. It says, this is dangerous. This might be dangerous. Pay attention to that, y'all. The amygdala itself is not responsible for the experience of fear. Its job is more appropriate to be as detecting and possibly responding to the presence of imminent threats or fear. So the thing about it is, the amygdala is the sensory, it's your radar. And that's the thing that happens. And so whenever we have this and we pay attention to this amygdala, we have it. But what happens when people have traumatic events occur, what is impaired, y'all, from then on is the amygdala. So the radar becomes impaired. It can't tell if it's dangerous or not dangerous, or it's maybe something that may be very normal and they interpret it as being extremely dangerous, and all of the things that go along, because it is blocked. And when you block it, the amygdala can't take the information from the prefrontal cortex or the sensory brain in order to appropriately tell the hippocampus, which says, do you run away from this, or do I fight this, or what do I do? And relate it to the thalamus to make the body do what it's supposed to do. That is what happens when we have traumatic stress. It occurs in that way. And so when it occurs like that, we have that circumstance. So the amygdala sends a message to the hypothalamus. It triggers the pituitary. It triggers the HPA. Cortisol is released along with other hormones. And guess what? It allows the brain to shut down the essential, non-essential components of the brain and focus on exactly what the problem seems to be. This is a normal stress response. You have to activate the defense mechanisms. The first reflex that we all go through, even if it's just for a few seconds, is freeze, or what we call shock. Freezing occurs when the amygdala detects a threat and signals the brainstem to inhibit the movement. If we see someone in an accident and we can't believe that just happened, or we're involved in some sort of environmental trauma, or a hurricane. We've got high winds coming this afternoon, and people have had 2 hurricanes in Florida this year, or within 6 weeks. You can imagine what they're reliving. And so what happens is you say, oh my God, the brain has to catch them, and it goes, what do I do now? So freezing allows that amygdala to detect the threat. It happens in less than a second. It's automatic, and it's beyond conscious control. The response shifts the person into a hyper state of vigilance for any possible threat that may be present. And you invoke the hypothalamus and the pituitary, which are huge players. Now, what I'm going to tell you at this moment is that when you're using psychoactive substances, you impair the chemistries of both the hypothalamus and the pituitary, so the amygdala becomes more impaired and is not as sensitive to these threats and responses to threats as situations. And then people want to, domestic violence is a great example of this. You wonder why does somebody continue to be involved with a relationship where they get beat every Friday night, or they're involved with some sexual assault, and that because brain shuts these hormones down and they cover, and you can't respond in a more appropriate way. And that's what we see. And again, the memory process is impacted. The hippocampus normally processes our survival memories by both encoding and consolidation. The amygdala processes the emotional memories, and both of these are extremely sensitive to these hormonal releases from the pituitary. When you impair the pituitary because of substance use, or because you've had previous trauma and have not addressed that trauma, guess what? You don't respond in the appropriate way. And then it creates what happens as a result of that. You create increased stress. You create release of catecholamines or fight or flight, cortisol. The opioids and endorphins are released. Oxytocin comes in and tries to offset the negative feelings. But the thing about it is, as you hit more trauma, these chemicals are reduced. These are the hormones and chemistry that I keep talking about being reduced. And so when you have these, you create this. The thing that's interesting to me is that when we drink and drug, we alter the same chemistry in a different way, but also in a similar way. And so when we see this, brain begins to, as people drink and drug, they begin to shrink the brain or age the brain. But when we look at trauma, y'all, look at this. Dr. Bellis studied brains of children who'd been abused were different. The one on the left is healthy. The one on the right, you can see a thin external layer covering the brain, the white area arching. See that white area there? The white is space. This shows atrophy or shrinkage of the cerebral cortex. So trauma also shrinks the brain. So if you want to know how these are similar, you will see this. Both lateral ventricles, on the other hand, increase size, were traumatized. The ventricles increase, and when you increase the ventricles, you reduce brain surface area. When you reduce brain surface area, you reduce brain function. The expansion of these ventricles are at the expense of brain tissue. Trauma physically affects the brain and how it functions. So trauma is significant. The reason that we want to address it in therapy as soon as we can, like if you were in a bank robbery, we have a critical stress debriefing, is so that this doesn't prolong and activate these long-term hormones and chemicals that will create this phenomenon. And that's why we try to debrief people as quickly as we can over stressful situations. And then the twin study, she looked at twins who were in discomfort for trauma. One had a history of trauma and one did not. What she found, the twin who had trauma on average had an 8-point reduction in IQ. The only distinguishing variable was the trauma. Lower IQ is a significant risk factor for other negative outcomes like school failure and juvenile delinquency. So the thing is, what this means is that people with trauma history also can have brains that have been adversely changed by that experience. So my definition of trauma is traumatic events cause a bruising of the central nervous system. The bruising become more extensive the longer the traumatic event lasts. It's like a bruise on your leg, or you have one that you just hit the table and it's a small bruise and it heals within a few days, versus the bruises that you have when you're in an automobile accident and have severe trauma. It takes months. As a result, the bruising, the automatic nervous system begins to short circuit several important survival aspects of the human brain by altering those neurotransmitters and neurochemicals that we've already mentioned and changing the pathophysiology of the neural pathways, as I've shown you in these recent slides. So let's talk about the trauma. Again, the triune. We got the reptilian brain, we have the mammalian brain, and then the neo-mammalian brain. Everyday experiences connect trauma will trigger 5 or more survival responses. Fight, we talked about. Flight, we talked about. Freeze, but we also can develop friend and flop, collapse and numbing, disassociation, and reenactment behaviors. The client's reptilian brain takes over, the ability to think offline. And so what happens with most trauma individuals is they think instinctually by looking at the world through those glasses instead of cognitively trying to figure out a solution of what to do. And the thing about it is they're not even aware that that's what they're doing. That's the thing that most people don't know. So we have the 5 F's of trauma: friend, fight, flight, freeze, and flop is what most psychologists and psychiatrists are now talking about today. So if we look at friend or fawn, that's another word. It simply means, please help me. I can't do this. This often refers to social engagement. And fortunately, when it comes to abuse survivors, their social engagement to some degree is impaired due to their primary needs of not being met in childhood. Therefore, they rarely, if ever, ask for help or advice from others. Because let's face it, if your primary caregiver abused your trust, why on earth would you naturally ever trust anyone either? Often in recovery from trauma, one of these main areas, we try to work with these individuals to learn how to trust and how to ask for help. Big deal. It's a huge deal when it says, leave me alone. I can do it all by myself. That's another word. And that's what we see with substance use disorders. Very similar to what we see in this type of trauma. Fight. It's all your fault. This is often used as a backup response if an individual finds that their primary fear response, their friend response, is ineffective. So if they come back and they say, I can't do this, help me, and there's no response, guess what they immediately do? It's your fault. Simply put, they fight as a survival strategy that can often result in a person's demonstrating overtly aggressive, subtle aggressive cues, such as use of language or behaviors. Flight. I have to get out of here. The third response seeks to put distance between the threat and the person. The non-involvement individual, the person that hides, fleeing the scene. In this case, a variety of chemicals get released, providing energy to leave and run. This might be why we tend to run a whole lot faster than normal when we're being chased. And y'all kind of keep that in mind. The adrenaline is produced in seconds and mediated by the primary instinctual part. So the thing about it is they're not just leaving, they're running away, which means they have a lot more energy as a result. Freeze. I can't. In this instance, when the brain comes to realize that the first 3 responses, friend, fight, or flight, are not working, I'll freeze. Freeze is a prominent response that almost always by those persons who have been sexually abused. They get frozen, is what I call them. Not just freeze, they freeze. They get in a frozen state. And realizing that befriending or fighting or fleeing the abuser is not possible, the brain goes into a frozen state, leaving the victim paralyzed. We see this a lot in rape trauma, where people want to know why did they do that and how do they behave and those times, because they cannot, they're in that frozen state. They cannot, and we can't. The survival techniques also extremely useful in getting through horrific ordeals because numbing chemicals such as opioids are released into the body, much needed to protect the mind and body. And then we see this again in physical, sexual trauma, rape, those types of things. This allows for the best chance of recovery and survival. Traumatic shame is created by this response. Not only is it trauma, but also an extreme shame as a result. Flop or faint. It's my fault or it's not worth it. Flop represents the last offense and comes into operation when freeze doesn't work. Often seen in hostage situations, flop is when the mind and body completely shuts down and the person becomes totally compliant to an abuser's demands and whims. Domestic violence, hostage situations. According to Rothschild, and I left this reference in your references in the end of the slides, the moment a threat is increased and when freeze is not available to put an end to the situation, the amygdala will go from sympathetic activation to parasympathetic, or what we call dorsal vagal, and I'll show you that in a minute. It is the point that the body will shift from a catatonic muscular tension to a floppy state where any muscle tension is completely lost, and both the mind and body becomes completely malleable. So a person totally surrenders and becomes what we call the perfect victim in this circumstance. So when we have trauma and intimacy, if you got trauma, there's no intimacy. There's only fight, flight, or freeze responses. So you put that in your relationship. If your relationship at a normal level where you have intimacy and trust and interaction, and then you go into a fight, flight, or freeze, there's no intimacy as a result of that. Peter Levine said trauma originates as a response in the nervous system. It does not originate in an event. Trauma is in the nervous system and not the event. And so when we look at the polyvagal theory by Stephen Portage, he's done a marvelous piece of work. The parasympathetic is the depressant side, the brake pedal. It stops everything as a rule. It helps us relax, unwind, and discharge from over-arousal of the sympathetic nervous system. The sympathetic branch is the gas pedal. So we got a gas, brake, go, stop, go, stop, go, stop. And homeostasis, we balance those two from go to stop. We kind of stay in the middle. And as we look at this, so when we look at the vagus nerve, which is the largest nervous component of the central nervous system, we have basically, according to this author, three parts. We have a parasympathetic side, we have a sympathetic side, we have a go side and a stop side, and then we have what we call the dorsal vagus, which is a partial stop side. Freeze, immobility is what we're going to say. And this is only activated in certain emergency events. The dorsal vagal is for emergency events, to let you know. And so, well, you probably think, my God, he's talked too much. I'm not real sure. Go drink you some coffee like I'm fixing to have right now. And that is good. Thank you very much. But what we have is the green light, the vagal response, which is safe, social engagement. And then the sympathetic is the fight and the fleas, which is the response to danger, which is also normal. And then we have the dorsal vagal system, which creates immobility. It creates the flop. It creates permanent frozen states of being, which ultimately are seen by the individual through a pair of life-threatening circumstances. So if we look at the normal system up and down, we have ups and downs every day. But the homeostasis tries to keep us in the middle. And as Stephen has talked about, during a normal process, we have sympathetic hyperarousal and easy discharge, but we stay within a boundary of arousal. We have a window of tolerance. Feelings can be tolerated, able to think and feel, even though we're having stimulation, if you understand. Then we have the threatening component. And what happens, y'all, with the threatening component, the sympathetic hyperarousal, is it goes above the window of tolerance. And what happens is you go in survival, and depending on the level of trauma and how much trouble, according to this theory, he talks about it can be stuck on or it can be stuck off. If it's stuck on, You have hyperactivity, panic, rage, hypervigilance, elation, and mania. I have a lot of ADHD diagnosed children who are trauma survivors because they're stuck on. But we never look at what's behind the hyperactivity. If you look at what's behind the activity, you find history of trauma because the brain is stuck on. Then we have stuck off: depression, disconnection, deadness, exhaustion, anhedonia. And we have all these antisocial individuals. But the thing about it is, if we look at the antisocial individuality and look behind, there's a history of trauma, and they may be stuck off. You understand what I'm saying? So there's lots of things that can be identified with this particular theory. And the thing about it is, I think it's so when we have it stuck on, we typically have people acting out, overly aggressive, loudmouths, bullies, etc. When we have it stuck off, you have self-destruction, cutting, mutilating, internal beliefs of low self-esteem, etc., etc., etc. So we have both of these biological reasons that we see behaviorally in many times. And so we got 8 trauma behaviors that come from this, y'all. And I want to mention these, and then we'll talk about treatment. We have trauma reacting, which is the experience of current reactions to trauma events in the past. And I'm just going to list these for you. There's ways that y'all could do, and these are things that people suggest that you can do to address these in a therapeutic milieu. But I'm going to tell you, experiencing common reactions to trauma events in the past. And this happens a lot in relationships, especially where the child is abused by the father and they marry and they have an abusive husband, or vice versa, abusive mother and they have an abusive spouse, some sort. We have trauma repetition, repeating behaviors or situations which are parallels to early trauma experiences. And the thing about it is, the only way that you understand that this repetition is that you have a comprehensive history of their life experiences and you look at what that's about. And then you have trauma bonding, being connected, being overly loyal, being overly helpful, being overly enmeshed to people who are dangerously shaming and exploitative. And so this is where we have that perpetrator victim syndrome that people become, and they want to change, or people they get involved with individuals in the correction system and they think they can change them, or men and women marry alcoholic spouses and think that they can work on. These types of traumas are part of that. Trauma shame, as I mentioned to you, the feeling of unworthiness and self-hate because of trauma experiences. Huge issue when, especially in mental health and substance use disorders. Trauma shame is the shame reduction. We'll talk a little bit about how we do that here in just a minute. Trauma pleasure. People want to know finding pleasure in the presence of danger and violence and risk and shame. And you have all these acting out behaviors, either from a physical standpoint or a sexual standpoint or whatever. And because they call it trauma, the piercings, tattooing, a lot of misfigurations have to do with trauma pleasure. People say, I love being this. Well, I guarantee you, if you look at the individual who has this or that, it's almost, there must be a significant trauma history present. Not always, but in the majority of cases. Trauma blocking, a pattern that exists to numb, to block out, or overwhelm feelings that stem from trauma of a person's life. Trauma splitting, ignoring trauma realities by disassociating or splitting off from the experience itself. And then trauma abstinence, depriving self of things you need and deserving because of traumatic. A lot of folks that we see that may be in the world of the homelessness suffer from trauma abstinence as a rule. So when we look at trauma treatments, and I got my time because the time is running out. There's a few common reasons why sharing trauma may be hard. So how do you talk to someone about trauma, and how do you support the person in disclosing? Well, the thing that the person needs to know, if you're suspicious, there's a fear of invalidation of the individual. There's a fear of judgment, not being believed. And also there's a huge fear of reliving the details because of the feelings it creates. And these texts that I showed you and gave you in the beginning help people understand what you need to do. Of course, you need to be appropriately trained and understand, but you can listen to someone, and this helps you understand how to listen to someone so that you could make a referral to the appropriate professional. Best practices of trauma-informed communication. Respectful of other life's experiences. Build healthy relationships. If you can build a relationship with them person, that's the biggest thing you can do, regardless if you know about their trauma or not. It's a big deal. Talking about trauma can be important, but don't insist on talking if the person doesn't want to. They may need time to be alone with their thoughts, and you need to tell them that you're there to listen whenever they're ready. Reassure them to care, and you want to understand as much as possible of what happened to them. But if you have a trauma history, be aware it can re-traumatize you if they happen to share things that may be similar to your trauma. So that's the thing I tell people. Be aware of your own history and make sure you've appropriately dealt with that before you start stepping into this world. The different types of mode of intervention, cognitive behavioral therapy, eye movement desensitization, reprocessing are probably one of the most effective behaviors that we have. Somatic experiencing with the appropriate hypnotherapy, transactional analysis, and of course, medications. I'll mention those. We got Minipress that has been used for post-traumatic stress. We've got Ceramycin, which is actually an antibiotic for TB, has been used for a number of years, and it looks to be maybe modified to be used more extensively in the next year or so. We have the beta blockers such as propranolol and others. We have hydrocortisone injections, the SSRIs, the TCAs, tricyclic antidepressant chemicals, and also morphine can be used to prevent under certain situations when it talks about traumatic events. Benzos, even though they're highly addicting, have been used in low doses under close supervision. Antipsychotics, as risperidone, and also the omega-3 fatty acids are being reviewed as we speak. Stigma. One of the things I share with people is to make sure that when we talk about trauma substance use, we try to eliminate stigma labeling. And that is a big deal. The language that you use and the issue. And again, the text that I showed you in the beginning help you with that to understand the appropriate language to be used. If you're going to talk to someone about substance use disorder or mental disorder or trauma disorder, that's what we do. So here's the take-home lessons as we get close to our time being up. Neurobiological changes can make memory consolidation difficult. They can't remember everything. The story may come out fragmented or sketchy. There's misinterpretation or evasiveness or lying. They can add to the story or not to give the whole story. The content of the memory is accurate. It just may take some time and patience for it all to come together. Most people, when they talk about trauma, and this is what I do with people, is if they're comfortable, have them write it down, have them put it on paper. And that way the story is there. The thing about it is tonic immobility, which comes usually as a result of rape, is often frightening. They are frozen. They can't move. They can't do anything. And until we understand, and just to be able to explain that to individuals, oh, this is what you're experiencing, is helpful for them to maybe move forward and get the appropriate treatment. Because it has to do with their self-blame. It has to do with the inability to seek help. And it also has to do with the thing about it is the disclosure of what happened is extremely harmful to friends and family. And it's helpful to explain what TI is, tonic immobility, especially as it relates to individuals who have been sexually assaulted. Service for victims, advocacy, the mental health service, to understand who's in the region that you're in that can provide these types of services. If it be substance use, if it be mental health, if it be trauma, and make sure that services are culturally appropriate. If it be for the Hispanic population, African-American population, whatever, services are developmentally appropriate for age. And again, this takes a little homework, but this is one of the things. So my concluding thoughts is there are neurobiological reasons for victims' behavior as a result of trauma. The criminal justice system is a 180 from victims' needs psychologically and neurologically. The criminal justice system shames individuals who may suffer from these substance use or trauma or mental health disorders. Every contact is an opportunity to help or to hurt. So be aware of that. Here are your references. I hope this is helpful, even though it was very quick. Again, I hope that in the future we'll be able to provide an expansive piece of information. And so now, if you happen to have questions, I'm glad to entertain them. If you'll put them in the chat box, I'll be glad to see if we can address those and answer those while in our time remaining. Thank you very much. All right, I got a question. What is PIP? I knew y'all were going to ask for PIP. Personal intrinsic pheromones. The attractiveness of individuals as we look at pair associations. The biological chemicals for love have to do with invisible sense. The reason that you were attracted probably to the individual with your first love is not because they were cute or funny or whatever. It's because your instinctual brain smelled their pheromone and it activated your oxytocin that created a desire to love that individual. So the PIP is about the biology. We see a lot of PIP with mamas and babies. Mamas love to smell their babies and they want to know why, because it stimulates the love that they have for that baby and that love that baby has for that mother. If you understand. And it is tied to the oxytocin dynorphin connection that we're just now beginning to explore. Fascinating stuff, but I'll guarantee you we've seen the behaviors 100 times, and you that are mamas out there and remember smelling that baby for the first time, and it's just it's an unconscious process. So when you deplete the PIP, you deplete the capability of loving, and you decrease oxytocin, and that in substance use disorders is what creates why the loved one in a family runs from their family with a substance use disorder and they do not want any help. It's because they have depleted that natural hormone that would bring them close together, and instead it drives them further apart. So I hope that helps. Other questions that y'all may have? Yeah, I hope y'all go pipping this afternoon. Anything else? Yeah. So, yeah. Okay. I don't see any more questions, so I'm not going to hold y'all up. So, all right, James, what about the new RNA treatment for meth? Jim, you always bring these great questions. The RNA, like DNA, RNA is day to day. And they think that if we have the correct option and the correct correction of RNA, we can diminish the need and craving, as I was mentioned earlier about trauma, of the craving for methamphetamine. It is new technology. It is brand new. It is, I think, theoretically, it has a great chance. And I have been a strong believer for many years that trauma, substance use, and what we do every day changes our RNA daily, hourly, minute to minute. So if we learn the sequence of how to do that when it comes to substances of abuse and how it may change our RNA and be able to revert it back to normal, then we can reduce the need and the craving for that individual. So there's a new approach. And I'm very happy that we have advanced the genetic studies to the point that we can even consider that. Great question, though. I think it's going to be very beneficial if we can correct it. It was fascinating that trauma is not the event, but in the body. That makes so much sense. It reminds me of the book, The Body Needs Keep Score. That is right, Carmen. And that's a question I can't answer that. When y'all will have the recording available, I'll let the folks here answer that. Esther can answer that for y'all or send you an email. But talk about neuroplasticity and trauma. Well,
Lisa, neuroplasticity is the adjustment of cellular membranes to day-to-day, minute-to-minute activity. We have a flexible component, and the cells adjust to the exposure of what happens in the flexible. It's kind of like a wave hitting the beach. We have a big wave that neuroplasticity of the cell will give in order for it to not be damaged. But when there's certain chemical COVID-19 changes plasticity, neuroplasticity of cell membranes, and that's why it's so destructive, because we have no natural protection. And so neuroplasticity and trauma, when we have that trauma, it damages that path, and that's why we see the reduction of the cells and the shrinkage of the brain. That's why I showed you that slide, is because we need this. And one of those things is that we have no natural protection, except that the brain will shut down, and it tries to protect itself by not allowing more information to be interpreted into the cellular membranes through neuroplasticity. It doesn't work very well, because that's why we have the different types of trauma that I just explained to you and the behaviors. But trauma does significantly impair the neuroplasticity of cells, especially in the parasympathetic and sympathetic nervous systems. Yeah. You're welcome. Great question. Great. One day I'm just going to open it up and have y'all ask me questions. I think I actually do better with questions than I do trying to give formal lectures. So, okay, anything else? Yeah, it is, Carmen. The mind and spirit are so connected. Biologically, they're chemical. Now remember that. They're chemistry. They're chemical energy connected to electrical energy back to chemical energy. That's right. We're all different types of energy. Well, y'all are welcome. I'm glad y'all are here. I hope that y'all found this helpful. And I'm hoping I am due to do another lecture series here shortly for these guys, hopefully after the first of the year, and we'll continue our discussions. So thank you very much. Esther?
Thank you, Dr. Norton. That was very, very informative, and we appreciate you very much. Thank you so much for your time. And thank you everyone for joining us today. And our recording of this webinar and the handout that he provided should be on our on our website within the week. Does anyone have any other questions? Dr. Norton, Carmen asked, is there a website, social media to follow your work?
I'm going to release a new website January. I have finally decided after retirement, I didn't want to, but I have a new website that should be up, and I'll send y'all the link and the connection capabilities here by the first of the year. So yes, I have 30 new presentations that I've done over this past year with and I've got a new series, just to let y'all know. I've got a new series speaking of the neuroscience of these types of disorders, and y'all just heard one of these. I'll be doing it for the Georgia Addiction Counselors Association. I think it's going to be January 26th and 27th. It'll be a 12-hour, 2 6-hour days, in order to cover the whole spectrum, where I'll have enough time to explain these things if y'all are interested. So, but yeah, I'm going to release that website here in January. Thanks for the question. Thank you.
There's not any other questions. We will end this. Thank you everyone for joining us today, and thank you, Dr. Norton, for your time.
You're welcome. Thank y'all.
Thanks, Merrill.
Have a great day.
Thank you.
Stay safe.